Boggy knees. Two are benign, one is quite serious and the other can be extremely serious. On this slide there is osteoarthritis, hemarthrosis, septic arthritis and traumatic arthritis. As usual, the answers will be at the end of the webinar, and I will speak to how the objective exam informs your observation of each of these conditions. Just a review of language. These terms have a tendency to be used interchangeably or incorrectly over time. If you are in a mind, differentiate each term. You've got to love this test, but the research behind it leaves something to be desired. The test is designed to give a simple, reliable means of pinpointing the source of low back pain to the sacroiliac joint. It is a type of test that I would have loved to have been associated with. Simple, obvious, and useful to even the newest graduate. No special skill is needed to carry it out, nor to interpret its results. In fact, it is really not a test in the usually meant way, but is really part of the subjective examination. Who knew that you could ask a patient where they thought the pain was coming from and have them tell you? It is only the degree of accuracy that is in doubt due to the methodology of the study. But even so, the test has its uses in eliminating the pains that are not from the SIJ. That is, the test is probably highly sensitive, so when a negative result is obtained, the likelihood is that the SIJ is not the source of the pain. The next few slides is a test in all its glory, plus an add-on that I've found useful but has no research evidence to back it up, just experience. So as always, you can take it or leave it on its merits. The test. The patient is asked one of two questions. Indicate with one fingertip where the pain is felt to be worse, or from where do you think the pain is coming. A positive test is that the patient puts the fingertip just medial and just inferior, about 1 centimetre by 1 centimetre, to the PSIS. If the patient uses a larger area of his or her hand to indicate the pain source and cannot localise it, then the test is positive. Or if the area is not precisely as Fortin's area, then the test is negative, indicating that the SI joint is probably not the source of the pain. It may be the case that the patient says that there are two pains, one of which demonstrates a positive Fortin test and the other something else. My take on this would be that there are two different sources of pain, one of which is the SI joint. The test does not give the pathology, nor will it be positive if the SI joint is dysfunctional but asymptomatic. I would also suggest that the test is not indicated unless the patient's symptoms are felt in an area that includes Fortin's area, or if Faber's or Patrick's test is positive to the same area. Fortin and Falco investigated Fortin's test in the American Journal of Orthopedics in July 1997, with 16 patients who were selected from 54 consecutive low back pain patients based on a positive Fortin's test. Each of the 16 was subjected to pain provocation injections given under imaging guidance that demonstrated that the pain being generated by the SIJ. 4 patients also agreed to pain injections on the asymptomatic side, and none of these reported the onset of pain. Because only those who had a positive Fortin test were injected, there is no information on false negatives, so no likelihood ratios or any other type of diagnostic accuracy assessments can be made. But it would appear that the test is very sensitive and is useful in ruling out the majority of pains from being generated from elsewhere. Additionally, each subject was interviewed, that is tested by 2 different people, and the same 16 were identified by the testers, 12 by one using only Fortin's test and 4 more by the others using Patrick's test plus Fortin's. This result would make the test extremely reliable, but for the fact that the number of testers, only 2, was so small. This confirmation by 2 different people has led many to suggest that the test is only positive if the same answer is given twice. This is patently absurd. How comfortable are you in asking the patient the same question twice as if they were an idiot and didn't know where their pain was coming from? If you are going to follow the research this blindly, then you need 2 examiners to ask a question, each blinded to the other's finding. It's ridiculous. In an attempt to rule out false positives, the 16 subjects were variously subjected to imaging and low lumbar disc and facet pain provocation injections. In 2 cases, these imaging and injections were not done as these patients had lumbar fusions and so deemed to be free of pain from elsewhere. In all cases, these ancillary tests proved negative. A few personal thoughts. First, Fortin's test is not suitable for identifying asymptomatic dysfunctions of the SI joint. Just the SI joint as the immediate source of the pain and not as an etiology for another pathology. Second, it does not determine pathology. Biomechanical dysfunction, fracture, systemic arthritis, etc. cannot be differentiated from each other by a positive test alone. Third, damage to the anterior SIJ ligaments may not necessarily produce posterior pain and so may result in a negative test. Therefore, while a false negative test may occur, it should be quite rare. Fourth, use the test to at least provisionally exclude the SIJ as a source of pain. Fifth, the negativity of the pain provocation injections to the disc and facets would moderately suggest that there is a degree of specificity to the test, but it is uncalculable. 6. You do not need the question answered twice, and certainly not by the same assessor. I've already demonstrated my contempt for this approach, but if you like, I'll do it again. It is a very dumb thing to do. It yields no further information and was almost certainly done for methodological rather than clinical purposes. Don't waste your time and look stupid. So I'm going to call this Jim's Rubby Rub test. It would be nice to have a test named after me. But once you see what this test is, you will see that it's also embarrassing in the extreme, not least because I'm sure that it can't be original. The test is as simple as Fortin's test, but takes a little more, not a lot more, skill. Essentially, it is palpating the sacral sulcus, including Fortin's area, with varying degrees of pressure as required to produce asymmetrical tenderness. Quite a lot of pressure may be necessary, and the skill comes in making sure that the pressure is equal on both sides, regardless of how much pressure is being used. The test is usable as an adjunct to Fortin's when it is probably redundant, but it's also usable when the patient does not complain of pain in Fortin's area, either spontaneously or when induced by Patrick's or Faber's test. That is when the joint is asymptomatic, but nonetheless dysfunctional. As I've already stated, there is, as far as I know, no research behind this objective Fortin's test, but I have found that it does tend to correlate with the finding of SI joint dysfunction from the biomechanical exam. I do understand and realise that I am conflating 2 unresearched statements here, one for the palpation test and one for the biomechanical exam, but I cannot be held responsible for the inadequacies of the researchers to prove or disprove clinical theory and practice. I have yet to find this test negative, either in the presence of a positive Fortin's test or in the presence of a clinical diagnosis of SI joint biomechanical dysfunction. I find it useful in the search for etiology of lumbar, hip and leg pain as a screening test for further examination of the joint. So if not Jim's Rubby test, then what? When teaching it, I call it the objective Fortin's test, and I apologise to Fortin if he doesn't like it, and if he wants me to stop using it, if he wants to let me know, I certainly will do that. To wrap up this webinar, I would say that Fortin's finger test is a very useful initial test when SI joint pathology is a differential diagnosis. It appears sensitive and it appears reliable. It is also quick and easy for anybody to apply and easy to interpret. The downside of the test is that its specificity is unknown, but this is less of a downside if you use a test to eliminate the SI joint as a source of pain rather than trying to include it. It may be that the objective component of the test in these circumstances may help you have more confidence in including the SI joint as a diagnosis, but I think the patient would be better served by following up with a more exhaustive examination. I would also recommend using the objective Fortins as an initial screening test when the joint is being considered as an etiology or a contributor to another issue. In much the same way as quadrant testing can be used to include joints without discussing specificity. We're just reviewing language at the moment and seriously not testing you. But language does alter over time. But when the language is technical, it shouldn't simply drift. The meaning of retropatellar syndrome is in the second part of the name, syndrome. A syndrome is a characteristic collection of signs and symptoms, but without an understanding of the pathology causing them. In this case, the pain is behind the patella, pain going downstairs more than upstairs, positive movement sign, etc. Chondromalacia, on the other hand, is a specific pathology that can affect any sesamoid bone, but clearly less frequently by far than it affects the patella. Chondromalacia would initially be classified as retropatellar syndrome until the pathological cartilage has been visualized, when the more definitive diagnosis would be made. Osteoarthrosis is degeneration of the joint, while osteoarthritis is when that degenerative joint is inflamed. Usually the reason for this is trauma or microtrauma. Tendinopathy is where the tendon is suffering from a pathology, and tendinitis is when that pathology is inflammatory. The tendon may also be degenerative, in which case it is called tendinosis. Arthritis is an inflammation of the joint, osteoarthritis, rheumatoid arthritis, traumatic arthritis, etc. An arthropathy is a simple statement that the joint is affected by a pathology that is unspecified. So, the soggy knees. Hemarthrosis and traumatic arthritis look similar in these two pictures. Although the effusion is spread throughout the knee with the hemarthrosis, while the traumatic arthritis is more confined to the suprapatellar bursa, but this can be different depending on the amounts of fluid. The main difference between the two is the rapidity of the swelling. Hemarthrosis occurs rapidly and is obvious within an hour or so, while traumatic arthritis takes some time. Often most of the swelling is seen the following day. Additionally, the fluctuance of the two tends to be different. Blood is more viscous and moves en masse, while synovial fluid tends to flow from one area to the other, more as a watery fluid as you push it. The fluctuant test, where the examiner palpates a joint line with finger and thumb and compresses the suprapatellar bursa to feel the fluid shift in the joint, can be useful. The way the fluid shifts is helpful in determining the type of fluid. It is also worth remembering that blood comes from the torn or broken tissue, so there is an immediate onset of the severest pain felt by the patient, while this is delayed with inflammatory problems. In the picture D, you can see the typical valgus deformity of both knees from OA, but this is variable. With OA, there will be a history of knee aching, stiffness, and probably intermittent swelling, and in this case, both knees will have some limitation of motion. Septic arthritis will probably be from a local wound, but not inevitably. The wound can occur sometime before the arthritis actually becomes established. There will be range of motion, loss, pain, and redness around the joint. The temperature of the patient may or not be raised, but should be tested with any unexplained effusion. If you're at all in doubt of this diagnosis, send it out to the emergency room, because when this occurs, the degrading of the joint can be extremely rapid and very, very extensive. I hope you enjoyed this review of Fortin's test and that you'll revisit it if you have stopped using it, or take it up if you haven't tried it yet. The short discussion on the use of research in Fortin's test sparked me to vent a little more. Currently, it is believed and has been demonstrated that at least 30% of all peer-reviewed articles published in all scientific fields, including medicine, is erroneous. There is absolutely no reason to believe that physiotherapy would be any different. This occurs due in part to skewing of the numbers by failure to publish studies with negative results or replication studies, even those that contradict a previous study. P-hacking, both deliberate and accidental, are also other causes of these incorrect publications, and there are of course other factors. I've included a seminal article on the subject in the supplemental materials. So your critical facilities are all you have to inform your practice, both in accepting published research and expert opinion, and in choosing which of these to use in a particular case. Be constructively skeptical of the research and of expert opinion and of your cognitive bias. Try things yourselves and do not blindly believe others regardless of whether they hold a PhD, a fellowship, a certification or anything else. You have to accept that experts generally know more about their fields than you do, but if what they are saying completely contradicts your experience, then be skeptical and demand not only better evidence, then better logic. I would be more accepting of somebody talking about research who has a PhD than a clinician doing so, and of course a clinician on clinical matters rather than a PhD. But if the claim is extraordinary, then regardless of who is making the claim, the proof must also be extraordinary. Be particularly skeptical of people stepping outside of their own area of expertise. The researcher telling me that I'm doing it wrong, or the clinician arguing against research, doesn't really impress me very much at all. However, there are instances when the researcher is right about clinical matters and the clinician about research. Keeps it interesting though, doesn't it? You are the final arbiter of your practice, and for your patient's sake, please practice skeptically. Of course, none of the above applies to me. You can trust what I say both entirely and eternally. I'll talk to you again in a week or so. Thank you for putting up with me. Bye.